Today we will discuss management of right main bronchial tumor obstructing the right main bronchus. This is a female patient who had an initial diagnostic bronchoscopy performed outside, and an attempt to do a biopsy caused bleeding, and then referred to me for biopsy. As I closely look at the tumor, a diagnostic bronchoscopy was performed, and then the lesion seems to be obstructing the bronchus intermedius, and the right upper lobe seems to be uninvolved and patent. Normally, we consider the first differential in this case could be a carcinoid tumor, considering the location being the proximity to the carina. However, when I look at very close examination on the imaging, the axial film shows that the lesion is like a single lesion, more like a carcinoid. But when we see the coronal section, the lesion involvement is beyond the wall on the medial end around the carina. So, normally, when we have a lesion like this, the best method to quickly relieve the obstruction is use of a snare electrocautery. Whenever we make a snare electrocautery, we use hot snare, and a successful loop decides the success of the procedure. So it's always better to loop around the lesion and block, and then we use a Arbe YO3 generator here with endocut Q mode and an effect of 3, and then gently loop around the neck of the tumor and then activate the foot pedal. So once the resistance is lost, the lesion is detached from the airway wall. As you can see here, as I activate, you can see notice some amount of bleed there, but manageable. And then you can see the free tumor now moving with respiration. So now we use the patient has a rigid bronchoscopy in place, and then we use a 1.7 millimeter cryoprobe through the flexible bronchoscopy working channel to get the tumor out. A 1.7 millimeter cryoprobe is passed through the working channel of the bronch, and then just gently touch the lesion and then slowly bring the tumor out. So once we remove the tumor and then make a quick inspection at the site, even you can see the cut margin of the tumor shows that the lesion has a very broad base. And that's the resected tumor. And as I run through the bronchoscopy, now you see the involvement. So the lesion is broad, extending from the proximal carina, around a centimeter from the proximal carina to the or lower lobe origin. So I just use a rigid bronchoscopy and then just core out the remaining part of the tumor to relieve the obstruction of the right main bronchus, and then remove those fragments using flexible bronchoscopic suction. I was able to maintain achieve patency of the right main bronchus after the mechanical debulking using the rigid bronchoscopy barrel, but as you note here, like there is some moderate to severe bleeding, but not compromising the contralateral lung. So usually manageable. with some time using suction and some topical agents, or we can also use a balloon tamponade in these kind of cases. So I take some time to control the bleed. Always make sure the opposite bronchus is not compromised when you have bleeding after this kind of tumor resection. So you can just tilt the bed a little towards the right side in case. Sometimes that can be very useful. And then slowly I note that the intensity of bleeding is coming down. And then I use some topical agents. Make sure the left side is clear. And then go and suction the right. And then I can see the base of the tumor is also involving the posterior membranous wall of the bronchus intermedius. And then sometimes you can even pack in some gauze dipped in adrenaline or some sort of topical agents like Tranexa, and then close the bleed, control the bleed. And then here I use a small Fogarty balloon just to occlude the area. These balloons come handy when you have profuse bleeding to get some time to localize the bleeding to the affected side. I can see the bleeding spot to be more on the posterior membranous wall there. Yeah, you can see the drooling of blood. The lower lobe bronchus, the middle lobe and the superior segment seems to be uninvolved, but the extent of the tumor is little longer. So we need to decide, depending on pathology, how we are going to submit this patient for surgical resection. We need to discuss with the surgeon on what's his plan to manage after this. After some time, you note that hemostasis is achieved with topical agents, balloon. It doesn't matter what we use, but the ultimate goal is to achieve hemostasis. Even you can push the Ritchie bronchoscopy barrel onto the side. But since I felt the walls are a bit weak and then the little obliteration of the bronchus, I did not want to take a chance there because I have a larger barrel in place. So bypassing the bronchus intermediate sometimes can be difficult. And then a quick CRE balloon just to inflate the area. We are using a 14 millimeter CRE balloon here. And then you see the medial wall involvement and also the ooze that comes from the posterior wall filling up the B6 segment there. So To quickly control the bleed, we then use a APC, and when we change the imaging modes, sometimes can help in localizing the area where the bleeding is from. And then here I'm using a side firing APC probe to just debulk the remaining tissue proximally and also distally to control the minor bleed, mucosal bleed that's coming from that area. Yeah, I think we achieve hemostasis here. And then a quick run bronch immediately post-op. You can see the patent right bronchus intermedius and the uninvolved lower lobe and the middle lobe. And then a quick run on the left side. So 2 days after we did a bronch to see if an additional APC session is needed. Here you can see the involvement, and then we make a decision along with the surgeon for on the next line of management, because the initial frozen here showed it to be salivary gland tumor, but on the IHC when we run, it turned out to be adenoid cystic carcinoma. So the parenchyma is completely normal here. So how we are going to spare, that's all the surgeon's decision.